Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Thank you so much for attending Improving Public Housing Health Center Service Delivery through Cultural Competence and Health Literacy session number 3. This is a live activity. All at this moment, all lines are muted, so feel free to use the chat box at the end of the presentations, or use the raise hand icon and your line will be unmuted. The National Center for Health and Public Housing is supported by HRSA. We provide training and technical assistance to health centers with emphasis on health centers located in or immediately accessible to public housing. There are around 385 health centers providing health services to public housing residents, and according to 2018 UDS data, they serve over 4 million patients. 107 of these FQHCs are public housing primary care. They receive funds from HRSA to provide services to public housing residents, and in 2018 they served over 800,000 patients. There are around 2 million residents living in public housing. There is some special information that I would like to highlight. 38% of them are children, and 38% of them have a disability. 83% of them are below the federal poverty line. And in regards to race and ethnicity, 52% are white, 43% are African American, and 25% are Hispanic. So it is my pleasure to introduce Dr. Abdin Novoa Rios, who is going to be leading this webinar and will be moderating the webinar. Good afternoon, Dr. Novoa Rios.
Thank you, Dr. Leon. Good afternoon, everyone, or maybe good morning for those on the West Coast. I want to welcome one and all to our continuing series on cultural competence and health literacy. I will be your guest host together with Dr. Jose Leon. As this is the third in a series of health webinars, let me bring everyone up to date with where we have been. The first webinar 3 months ago, roughly, was on cultural competence and its role in public health, both at the personal or individual level regarding everyday behavior, as well as at the organizational level regarding agency policies and procedures as examples. The focus also was about understanding the implications of cultural shifts as a result of demographic changes and increasing racial numbers, and then learning how cultural competence helps bridge those gaps. Now, the second webinar focused on health literacy and its many ramifications, from reading prescription bottles, as you see here, to misperceptions about personal health that patients and providers both take for granted, but often fall through the cracks when views are inconsistent, or when there are mismatches between facts and fiction. So we talked about strategies within that context. Now, for this third webinar, and forgive my poor drawing here, we're going to be focusing on health literacy and its many ramifications in terms of pulling all of this information into practical application in community outreach as community health centers, CHCs, and community health providers, CHWs, or Promotoras, work together. So the first dimension here is about providers having the right information, but the other dimension is how this information is communicated to clients. In other words, how the community is engaged in accessing accurate health information as well as how clients can be driven to be proactive about their health and receive the right information through various forms of engagement and communication. So in assembling what has been learned from the past two webinars and in looking at how this information relates to the delivery of health services, especially during an epidemic like COVID-19 currently, the role of community health centers and health workers becomes a salient factor in the delivery of services. Now, here a number of questions surface as they relate to what is the effectiveness of current approaches and efforts. Secondly, what are the challenges facing the system? Third, what has been learned from the process, such as impact, outreach, efficacy? And finally, what are the best practices or good examples or illustrations of that? So now I'm reflecting on what has stressed when talking about racial minorities and the workforce as well as today's COVID-19 pandemic. We must emphasize that many of our community members represent the backbone of the essential workforce and their family. And so it is a bit of a mixed bag in terms of the diversity of our population outreach. And so during this pandemic, upon reviewing the conditions of low-income workers, together with that of the needs of persons with poor access to health care, and then low levels of insurance, plus already poor health conditions, with many of them living in densely populated households, together with lower levels of health literacy and greater exposure rates by frontline workers or family members who are working essential jobs that require being exposed, like grocery workers, agricultural workers, janitorial workers, those in the meatpacking industries in the Midwest, and the like. It is no wonder that low-income and racial members among them are dying at disproportionate rates, nearly twice the rate of other persons infected by the virus. So this means that certain populations that suffer multiple conditions increase their risk and are more susceptible for infections. Accordingly, these populations are at major risk. But as another example, one which we did not mention last time, but it bears mentioning, tribal Native Americans on Indian reservations, especially the Navajo reservation, now rank as the third highest group for COVID-19 infections, as well as deaths, after the states of New York and New Jersey. These are all startling data. As a result, we're facing uncharted waters, but we have systems in place. So the question is, how effective can we be and how can we improve services in the arena of public health and community outreach and service delivery? For example, there is considerable misinformation that runs rampant against many of our best intentions and counterproductive to many of our best efforts. This concerns issues regarding anxiety, under stress, under a pandemic, and inaccurate information about health. So what can be done? Unquestionably, mental health and overall stress is a concern resulting from COVID-19. For example, domestic violence has tripled, petty thefts have risen enormously, and the rate of DUIs and accidents have exploded based on a per capita for those who have been driving, among other behaviors that result from being cooped up or confronting high rates of unemployment or anxious to ensure that all family members are adequately fed, and for multiple other reasons. In this context, it is notable to understand that since most people want to receive good news, they can easily succumb to false information, as they already want to respond to favorable information and favorable news. In this quandary, we are susceptible to wishful thinking. Desperation clings to any semblance of hope, even when we think it may be false. So here it is difficult to know what information is reliable and accurate, which makes all of us somewhat vulnerable to misinformation. So under current conditions, it is most critical for responsible leadership to know when to step up, but maybe sometimes when to step down. So messages must be clear. This is the time when key ingredients of strong leadership and trust must step to the plate. This includes full clarity, transparency, and candor, as well as consistency in messaging reinforced by overly communicating. Now, regarding this latter, it does not hurt to repeat sound principles and continuous mantras against false information, even though it may sound repetitive. Because know that there's counter-information through the internet or through the social media, among other fountains of misinformation, or what I like to call lousy information. These negative voices must be squashed to ensure health information is accurate and based on sound evidence rather than hearsay, wishful thinking, or just plain fabrication. As many people are hurting, even angry, it is our role in public health to provide healthy doses of great clarity, much compassion, and full understanding within this mix of voices and opinions. So, under anxiety-producing conditions, and the crisis we are all experiencing is certainly at the top, a new set of normal behaviors emerges so that it becomes okay not to be okay. In fact, this may be normal nowadays and to be expected, but that there are solutions and there is hope rather than despair. A collective wellness is essential to combat the seeming frailty of wellness and assure mental balance. So with all of this said and done, the key question is, how is this best communicated and how do health providers fit into the picture of our outreach and communication through our health centers? So with these scenarios in mind as backdrop, and without further ado, I will turn the start of our dialogue over to David Preston to kick off the process. But let me just say, we will be mindful that each panelist will have about 10 minutes of presentation before we open the session at the very end for Q&A for an additional 15 minutes of presentation. So as an introduction about David Preston, he is the Director of Community Outreach at the Community Health Center in Northern Texas from Wichita Falls that covers over 10 counties, many bordering the state of Oklahoma. David has been at the center for nearly 6 years and has much to share about how the center conducts community outreach among its other services. His formal preparation is in mass communication and public relations, where he has now served in multiple roles, including producer director, in advertising, marketing, public affairs, and communications. So David, it's all yours. Now to you. Thank you.
All right. Thank you so much for inviting me to do this. Community Healthcare Center, as you said, is located in north central Texas, basically the center of Texas, right below the Red River that separates Oklahoma and Texas. Our federally qualified health center began in 1994 and currently serves a 15-county area here in North Texas. When I started about 6 years ago, the FQHC had 4 clinical sites and served about 15,000 unduplicated patients with over 30,000 encounters. In 2019, we served over 31,000 unduplicated patients with over 108,000 visits. For 2020, we do see more growth in patient volume and clinical sites, and the patient volume being, because of COVID and unemployment, that uninsured rate going up. Currently, we have 7 clinical sites, and with additional 2 clinical sites coming soon that I mentioned. Both of those sites would be school-based health centers, one with a local elementary school here, and also one with a local college. For 2019, just to give you an idea about our patient population, as far as ages go, 8% was 65 and older, 54% was 18 to 64, and then our pediatric population comprised of 38%. And then for insurance status, you can see there on the right, 32% was Medicaid and CHIP, 11% Medicare, 24% were private insurance, and then 33% was uninsured. So the role of the community health worker and our outreach here in Wichita Falls has changed tremendously over the years. But, you know, I started here, like I said, 6 years ago myself, and we also have navigators and certified application counselors with the Community Partner Program and the Health Insurance Marketplace. The certified application counselors and navigators, they offer free and unbiased assistance and enrollment with Medicaid, CHIP, SNAP, TANF, and also through the Health Insurance Marketplace, the ACA. We also have our Nurse Family Partnership Program here at Community Healthcare Center. They have registered nurses that go to the homes of first-time expectant moms and do home visits weekly, and helping those moms navigate the world of being an expectant mom, and then when the child's born, still continuing those home visits and helping them grow as a parent through the second birthday of that child. And then we also have other staff members that I'll get to here in a little bit that help with outreach. One of the biggest challenges as a community health worker when I started here was getting to help staff understand what outreach is, what it can do for the health center, and how important it is for the health center. It's the key component that helps the success of a health center in our community, and it's vital that, you know, we are an active part of that community. I remember when I started here about 6 years ago, I visited with an executive director of a youth opportunity center here close to the health center, and I asked her how we could be more of a part. We were still a part, but I wanted to see how we could be more of a part of our community as a health center. And she said, the only way you can truly be an integral part of the community is to be active and involved. You will eventually be accepted into the community then. And that sings to me because, you know, to be active in the community is probably key for every health center nationwide, and be a part, because you have to think that the community, before they can entrust our health, their well-being, and their families to their care, they want to see us active and involved. So the past 6 years, when I first started, I was brand new to this kind of organization, and I wanted to figure out what all these events were about and everything was going on. So we started going to every event in our 14 to 15 county area, and, you know, trying to figure out what all there was to offer for the health center. So why did we do that? Number one, we wanted to find which ones were best for our health center to attend, which ones were going to be the most effective. You know, we also wanted to get ideas from other organizations regarding outreach and network with them for referrals with their clients to become our patients. And then also find out more about the needs of our communities we serve. That was crucial that we find out those needs. So for over a year, we did this until we've covered all the different events. And it helped us understand our communities and our patients. It helped us understand the challenges and the barriers in our communities, and helped us, you know, understand what they needed. For the Public Housing Authority here, we attended a lot of the resident housing meetings. We, you know, did different screenings and stuff with the public housing. We held booths. We did back to school events with them. We got with the Red Door and Green Door, which works with our senior citizens here in our community. We went to various meetings with our Head Start organization. We also, and we still do those Head Start organization committee meetings, and we also still attend a joint advisory committee meeting with our Public Housing Authority, all to make sure that we are a part of our community and we understand our community. So let's talk about some initiatives that came from all this. So our community health workers, our outreach workers, are not the only ones that go out now to these events. We get a lot of the providers, the nurses, the dental staff, other support staff to go and attend a lot of these events and meetings. Why? it bridges the gap and brings the FQHC as a team to get the team together. It gives a clearer picture about our community, and it gives the community and future patients a chance to meet staff and providers. I can't tell you how many times a provider has met a new patient at one of these events. It's very important. And then, new providers that are coming to our center that are joining our team, we definitely encourage them because it gives them a chance to learn about our community. They may be coming from another city, another state, even another country, and it helps them understand the different populations that we have here, some of the communication barriers that we have here, some of the other barriers and the health literacy barriers that we have with patients that they may need to address when they see these patients. So definitely a very crucial tool to have new providers join us. We have administrative team and leadership join us to help them better understand outreach and what our community health workers do in our community. I cannot stress enough how important for the outreach staff to get the other staff of the health center involved. It really helps that whole center team approach to our community. One thing here, we tout ourselves as Team CHC, and all our staff will talk to you about Team CHC every time we do an event. We hashtag Team CHC. It's always about Team CHC being involved. So some of the major events that we got our staff and our providers and our dental staff and everything and support staff active and involved in, Project Back to School, that services about 3,600 students here in our area that are on free and reduced lunches. We do dental screenings there. Our dental department comes out and does some amazing screenings with the population there and the kids and visit with the families. The Safe Kids Halloween, it's a great safe place for the kids to trick or treat and the disabled kids that may not be able to go to trick or treat in neighborhoods. This is a great event and the staff loves to get involved. Our pediatricians love to visit with the kids in this setting, and the kids love to see their pediatricians in this setting. Our free sports physical clinics that we began a few years ago, this is where we offer free sports physicals to the youth in our community, whether they're in middle school, junior high, or high school, or participating in youth sports leagues. And the staff love these. They get very active and involved. Our whole clinic gets involved in each of these clinics. And we did about 1,600 free sports physicals last year. And what's crucial is I visited with a mom with 7 children. Before we did these, she had to choose out of those 7 which child got to participate in sports because she couldn't afford all the sports physicals. Immunization clinics with our schools and our Head Start program, health screenings at our local YMCA that the nurses go out and do, resource fairs that our behavioral health department gets involved with the resource fairs that CPS and APS and state workers get involved with, very crucial for referrals. So I can't tell you how important it is to get staff involved in stuff like this. Now, let's talk about challenges with COVID-19. Everything came to a stop for public events and stuff that we attended. So we had to find some different best practices to do with our outreach. And so we began some digital strategies with social media. We got our pediatricians involved to talk to parents about what they're going to see when they bring their child in. How's the process going to work? Is it safe? What precautions are we taking? Also talking to them about the well child visits that we saw a decrease in, especially with the immunizations. We wanted to encourage patients that it's safe to come in. We're taking all the precautions necessary for your child and your family to be safe to come in to get those immunizations. Last thing we want, and the American Academy of Pediatrics stressed, is, measles, mumps, or bacterial meningitis taking hold with COVID-19 as well. So we really got the messages out, and we saw an increased rate in our well child visits and our immunization rate. And then we also reached out to our news media, and they grabbed on, and they did some of these same stories that our providers did on our social media. And then we also had the trouble with our certified application counselors not having as many referrals and people coming in. So our providers started listening to patients and their situations in regards to loss of employment and insurance and referring those patients to us. So definitely a challenging time with COVID-19, but some of these practices that we've put in place is crucial. And we're about to start doing some more about face masks, wearing face masks in public with our staff as well. So definitely encourage you to explore the digital solutions to do outreach in our community during this time of COVID-19. Thank you so much.
Thank you, David. And now for our other panelists, I want to introduce Susan Vega as Alivio Medical Center's Programs Manager, which serves the southwestern sector of the city of Chicago and the two outlying suburbs of Cicero and Berwyn in Illinois. Susan leads teams of staff and volunteers helping older adults and families in the community, while also managing Alivio's Chicago Family Case Management, Women, Infant, and Children's, or the WIC Supplemental Nutrition Program, as well as the Community Health Education and Promotion Team, wearing multiple hats. So Sue will now take over the reins and presentation and give you a different but complementary glimpse of another health center.
Okay. Hello, everyone. Let's see, here we go. Alivio is a federally qualified health center. We're on Chicago's near southwest side. And if anybody knows Chicago, we're kind of, imagine a pie wedge getting wider and larger as you go further west. Those are some of the largest contiguous communities that are largely Latino, mostly Mexican and Mexican American. And we do also have a growing Chinese population because one of our clinics is located just west of Chicago's Chinatown. And Alivio's mission is, actually part of our logo is to be an active presence for a healthy community. So our founder always saw this as access to healthcare, as well as advocacy around access to healthcare, as well as immigration policies and workforce development. So early on, the leadership at Alivio saw community health workers as a logical extension of clinicians and healthcare providers, because we always knew that in not every single case you need a doctor or a nurse or a dietitian. Sometimes it's easier for the messages to be distilled in a way the community can best digest by other people like them. And then, of course, there's also the realization, the knowledge that there are not as many bilingual, bicultural healthcare professionals available to serve our communities. So this is kind of another way to grow our own. So the current health education and promotion program team was built on an original concept called Compañeros en Salud, which was specifically to work on improving people's chances of not developing diabetes. There was a diabetes prevention program that morphed into something a little bit broader that included diabetes self-management. And all of the programs have to do with, they're all evidence-based and have the ultimate goal of self-efficacy and improving one's own healthcare. So we did a children's program. We've done Tomando Control de su Salud, which is a Stanford product, and Alzheimer's awareness. And currently we are doing Comprando Rico y Sano, which is a national program, as well as the diabetes prevention program and HPV awareness in the community. We're also part of a pilot, which is based in the near southwest suburbs, and it's a consortium of organizations where Alivio staff is really taking the lead at modeling what best practices look like for community health workers. So hopefully that will have a broader impact. Currently, the Promotoras are working closely with providers who often refer people for specific health issues, and there has grown more and more awareness of how important outreach and community health workers can be to overall health. So prior to COVID, we were doing lots of group work, one-on-one sessions, presentations, community events, and they were often planned on kind of the natural community themes that come up over the year, including Posadas, Dia de los Reyes, American Heart Month. Mother's Day was a big thing. Father's Day, we were hoping this year was going to be smashing, and National Diabetes Prevention Month, and some of the other health promotion and awareness months. But our events tend to have a distinctive Mexican and Mexican American flavor and accent. And of course, all of that came to a screeching halt in light of the emergency. So because the community health workers are nimble, dynamic, and highly adaptable, we moved in to fill the void fairly immediately. A lot of the work has been around COVID-19. People have lots of questions. I think one of the other speakers talked a little bit about how important it is for the right information to get out and for people to hear it over and over and over again. And that couldn't be more true. So we've participated in community forums, live events, we're doing workshops, we're doing presentations, and we're answering questions. We have also done a lot of social media platform work in partnership with the Ventanilla de Salud at the Mexican consulate, and we also have a mobile unit, and the program is funded by another entity of the Mexican government, and that has a mobile unit, and it's called Juntos por la Salud. Right now, our community health workers are out doing a census awareness caravan. We've done a number of outbound calls, and we've been referred to take inbound calls, specifically around the facts and myths about COVID and what people can be doing to better protect themselves and their families. We are right on the front lines of essential workers. We're just southwest of the Chicago Loop. Lots of hotel workers, restaurant workers, grocery store clerks, the whole gamut. And we have quite a number of cases. We're in Cook County. We have one of the highest rates, and it's been an interesting challenge to bring the distilled message about what we need to do as a community to better protect ourselves. And of course, we have lots and lots of families where there are multi-generational people living under the same roof. Lots of times mom is home, dad is home, and the kids are trying to do school. And so we're documenting those stories and those struggles so that we can better prepare for what seems like it's going to be a long situation that we're going to be in. And finally, these are just some of the funders who have helped us establish and implement this important work of community health workers. Community Promotora Foundation, Healthy Communities Foundation, and Unidos US, which does the Comprando Rico y Sano program. So we'll see what lies ahead.
Thank you, Susan. And and continuing with our panel, let me introduce Celine Putilla Maria as a community health worker. And she's from the community health, she's the community health coordinator at the Shawnee Christian Healthcare Center in Louisville, Kentucky, where she has served the past several years. Celine received her master's degree in community counseling after her bachelor's in psychology. She works primarily in the community sector to meet patients where they are and to better understand, advocate, and manage barriers to health and wellness with the goal of building resilience and improving health outcomes. So Celine, the baton now goes to you. Welcome.
Thank you so much. I'm really happy to be able to participate. Just get my slides going. All right, are you all able to see the slides?
Yes.
Okay,
Yes.
great. All right, so as mentioned, my current title is Community Health Coordinator, but I'm trained as a community health worker. And I work at Shawnee Christian Healthcare Center, which is a federally qualified healthcare center in West Louisville in the Shawnee neighborhood. So our organization was formed in 2008, and this was done in collaboration with the Shawnee Neighborhood Association. We were actually able to facilitate a needs assessment so that going into the community, we weren't making any assumptions about what the community needed. And from that needs assessment, the community identified that a healthcare center was one of the most needed resources at that time. And so we officially opened in 2011 and received our FQHC status in 2015. And in 2016 is when we began our school-based health services, and we had wellness centers at 3 different schools, along with a mobile dental care at 7 different elementary schools. But since COVID-19, we have had to place those programs on hold, unfortunately. But in 2017, we were also able to add dental services, which is where that mobile dental care support came from. And we also have behavioral health services on site as well. So we only have 1 location right now. I would say we're relatively young and are looking for other opportunities. But overall, our goal is to provide comprehensive patient-centered care that is integrated and easy to access. Gonna try to go to the next slide. 1 second. So this kind of just provides some information about our patient impact, but we serve primarily, most of our patients have low incomes, they're publicly insured. Some of our patients are uninsured, which we have support for that as well. But as I was saying, we utilize a whole person care model and engage quality improvement on a regular basis, and we recognize that the lives of our patients are really complex. So our main goal as CHWs is to assist in providing resources to help them overcome barriers. And we understand at this center that so much of what determines overall health isn't necessarily fleshed out in the maybe 20 minutes or sometimes 30 minutes or so that a provider is given to interact with a patient in the clinic, which is why we started providing CHW services to act as a link or a liaison between the patient and the provider to help identify barriers to care and screen for social determinants of health that might exacerbate different barriers. So because of our unique understanding of the communities we serve as CHWs, we're really able to establish rapport and bring information back to the providers that can help them contextualize the patient's lived experiences. And that way, if we have providers and patients maybe who have different cultural backgrounds or different lived experiences, we're able to provide information that providers can use to inform their care. And so a lot of our role here at Shawnee Healthcare, we provide different supports. I have been overseeing some of our health education programs as we've developed. So some of the supports that we offer include diabetes self-management. We have a blood pressure self-monitoring program where patients are able to receive a free blood pressure monitor. And a lot of that has come through partnerships, the community partnerships we've established. We even have a program with the YMCA where patients, in addition, can get 3 months of a free membership to the Y within that program. We have smoking cessation support where we offer free nicotine replacement therapies, and I'll get into a lot more of that as we continue the presentation, but essentially providers are able to meet with patients and refer for CHW support, and in many cases we're able to do warm handoffs where we can actually come into the clinical room and meet the patient and try to provide some reassurance, get to know them a little bit better, and identify a plan for support. And really that demonstrates the integration of our care. We try to be a one-stop shop as much as possible where they can get medical, dental, behavioral health, and community health services in one place. But in addition to that referral process, we also have a risk stratification process for outreach to patients that maybe we don't see come in recently, and we also engage in other types of outreach work as well. And so our program started in 2018, so it is also relatively young. The community health workers we have on site were trained through a curriculum created by the Appalachian Kentucky Healthcare Access Network, also known as ACHN. And we also joined the Kentucky Association of Community Health Workers and are now a part of Louisville, a more local association of community health workers. And some of our goals with this group is to, they have formalized the CHW certification process, and we hope to make that support a billable service in the future. But in general, we get together as groups to get training and to discuss the supports that would benefit the people that we work with. So as I mentioned before, some of the other support services I left off, we have a smoking cessation support where our patients can get free nicotine replacement therapies, nutrition education that we provide in collaboration with partners such as Dare to Care Cooking Matters and the Kentucky Office of Extension office that helps us out with those things. We have medication management resources, general care coordination. We have an emergency food pantry on site, and then in general, our patients know they can reach us for resource navigation, whether that's connections to insurance. We also have certified application assisters, help with transportation. We've been able to partner with Metro United Way to offer Lyft rides, up to 10 Lyft rides for patients to get to appointments with us or specialists. We try to work on housing help, employment, education, and then a lot of what we do also is advocacy. Our community health workers kicked off a Housing for Health campaign at the beginning of this year. And then we have other resources to help with the lack of bilingual CHWs we have. We often utilize our Pacific Interpreters program when needed to make sure we're being inclusive. And so with COVID-19, of course, as you all have mentioned, a lot has changed. Much of our services now are virtual visits, but our dental office is open for emergencies, and we are able to see some patients depending on what the need is in the office. What the CHWs have noticed is that many of our patients lack webcam access, or even maybe lack some basic skills for navigating the internet and things like that. And so we have reached out to the mayor's office to participate in their digital inclusion program to learn how we can help our patients get access to free internet services with AT&T and Spectrum, as well as how to help them get access to low-cost tech devices as well, so laptops and desktops for a much lower price than you might find them regularly. And we have been also just getting information about different resources, where patients can get the most up-to-date and accurate information about COVID-19, making sure they know how to look into their care stimulus checks when, since so many people are relying on that support, we want to make sure they have access to whatever resources they need to get information about their checks. And we've noticed an increase definitely in food access issues, but luckily we were able to establish a relationship with Dare to Care to keep our emergency food pantry stocked. And so some of our CHWs from time to time will deliver food bags to some of our patients who may be homebound or have difficulty getting out, and then connecting them with other services like Meals on Wheels, just making sure that they have information, because so much of what causes barriers sometimes is just a lack of information. So that essentially summarizes what the CHWs do here at Shawnee Healthcare.
Thank you, Celine. And that completes our formal presentations and from the panel. And so now I'll turn it over to Dr. Jose Leon, who will guide us through a question and answer process.
Dr. Leon, I think you may be muted.
Thank you. I believe that you muted me, but anyway, thank you. Thank you so much, Abdeen, Sue, David, and Celine for these wonderful presentations. Thank you for sharing with us all your outreach strategies and everything that you do for the community. We are going to start our Q&A. You can either use the chat box and type your question, or if you would like to verbally ask your question, please use the raise hand icon and your line will be unmuted. Please make sure that you ask your questions through any of these two options. And while you type your question, I'm just going to remind you that our next session is going to be on June 10th. We have the learning objectives here. Please, we appreciate all the collaboration, your support, and your attendance. At the same time, I would like to remind the audience to please complete the post survey, give us your feedback, and you can also visit our website where you can find different information on what we're doing. So thank you so much for your presentation. Sorry, I am having some technical difficulties on my end. So let's start with the Q&A session. If you have any questions, please again type your question or ask your question verbally. Any questions, Peter?
Yes, so we have one question that is from Sonia del Rio, and she says, do your CHWs get state certified?
Can you repeat the question?
Yes, do your CHWs get state certified?
In Illinois, there is no such certification yet. We are part of a group, an advocacy group that is trying to find common ground about how we can move to that level. There's lots of research being done on the impact that community health workers have, and there's a movement for it. And there has been for a number of years. We were hoping to make a little bit more headway before all of this started, but I think that what we will find has happened over the COVID-19 era is that we will be able to present even stronger evidence about how effective community health workers are.
Yes, and I can speak on that as well. This is Celine. In Kentucky, there is none as well, but we just got approved for our certification process, and our next step is just to figure out steps to making that service Medicaid billable, but we're not there yet.
Thank you so much for the response. Do we have any other questions today?
Not right now at the moment.
So let me just say, this is Sue again, just one more thing about certification and billing and all of those things that are very important. One of the things that we have found is that we want to make sure that the people who have been working as community health workers are not excluded because of a certification project or certification process. We have lots and lots of people in our communities that are undocumented who have either been volunteers, or we have found creative ways to fund them through stipends that private corporations and foundations have been able to support. So we want to make sure that while we are, I don't want to say legitimizing, but formalizing the role of community health workers, we're not losing some of the people who are the best at it.
Thank you, Sue. Thank you for the follow-up response. Sue, a question. During your presentation, you mentioned the community caravans. What is exactly the role of the CHW, if any, and what strategies you are using to make sure that you are taking all the precautions now during the pandemic?
Right. The caravans are mostly about raising awareness, and we're advertising them on Facebook Live and on our website, and there is not a lot of contact with the general public during the caravans. There have been some occasions, and I think they were actually going to try this out today, is to end up in a place where there's sort of some stations where people can pick up PPE and information about, today's event was about census, and others have been about looking out for the most vulnerable people. Another one was about where to find food. And the community health workers have been involved in organizing the events, participating in the events, and then doing evaluations after, and also making sure that the messages are consistent with CDC advice and specific to our community.
Great, thank you, Sue. Any other questions, Ire?
Yes, so we have one question, and it says, how do you use your CHWs to address the structural inequities present?
I can speak on that. I would say I see that most right now in the Housing for Health campaign that we've kicked off here locally, and really trying to expand that initiative statewide so that CHWs around the state can be aware of the work that we're doing and contribute. But we're actually meeting with an advocacy group here called Kentucky Voices for Health to talk to them about the experiences that we have when trying to help our clients navigate through housing issues. I think it really speaks, it just kind of makes a difference when it's coming from someone who actually has worked directly with the people most impacted by the effects of structural inequities and things like that. So we're able to amplify the voices of our clients, and our clients trust us. And they're able to share things that maybe they might not share otherwise, or even if they did want to, may not know how to get their stories out there. And so our goal really is to make that connection the same way that we do between provider and patient, but also between local representatives and things like that and the community members, and to outline choices that they have to speak up for themselves and the power that they have. I think a lot of times people feel discouraged because it's hard to see actual change happening, and so people may not have the confidence to speak up and talk about what's going on around them. But if we can provide those avenues and make it a little bit easier, and have them have a support, someone they can kind of process those experiences with, I think that is really going to make a difference in our campaign. And so that's just one of the ways that we do that, is really just by listening to the stories that our clients experience and making sure that these stories are heard, and that they know that they have power to make changes in their community if they come together. So just kind of modeling some of those efforts.
That's great. Thank you, Celine. Anyone else would like to complement what Celine said? Sue, David?
Yeah. So we are, we participate in a number of consortia collaborations where the community organizing entities and housing entities all come together around various efforts. There's something called the Pilsen Planning Commission, where we make sure that people in the community know what's going on and are at the table to talk about the things that are happening to them. I think Celine is right. We have a very specific kind of relationship that other organizations don't, because we are talking about people's health and what we call the pressures, what sometimes other people call, the social determinants of health. We speak in a language that our community understands, and the community health workers are the community.
Thank you, Sue. There is a question, and this question is for anyone on the panel. What has been an example of change in your approach on outreach to the community as a result of your learning over time, and how were you able to make the change?
Can you repeat the question, please?
Sure. This is basically two questions. The question says, what has been an example of change in your approach on outreach to the community as a result of your learning over time, and how you were able to make the change, and how do you know you needed to make such a change?
I think one of the things that we've seen over the years, as behavioral health became much more a much more important part of overall health, and there was actually now funding to help us provide behavioral health services to all of our community. That was a time when there was a shift, and the community health workers program had already been hearing from patients, clients, community people about how important that was and continues to be. And so the shift came, and we pivoted to make sure that as we look at providing health services for the whole person, that is also something, the emotional health of our community is something that is just as impactful as some of the other things that sometimes are risk factors for developing or managing chronic diseases, especially. So the short answer is to listen to the community.
Thank you, Zu. Is there any other questions, Fide, in the queue?
Yes, we have one more.
Okay.
And it says, do your CHWs have any specific guidelines for assisting patients with health literacy issues?
Yeah, in almost all of the curriculum that we've used or has been developed, we do quite a bit of providing information and opportunities for people to practice how to talk to their providers and make the most of their healthcare visits, how to identify when something looks like it might be good advice on the internet, for example. So we try to integrate that into all of the various subject matter curriculum that we're working with.
Yes, and we do as well. So the RCHWs receive the baseline training to cover the different competencies that the group I mentioned, ACAN, has developed. But in all of our health education programs, we use different curriculums as well to make sure that our CHWs are equipped with the information they need to provide good support. So with our diabetes self-management program, we use the curriculum called DEEP, Diabetes Education and Empowerment Program out of UIC in Chicago. And then our smoking cessation support comes through the Freedom from Smoking program. So our CHWs receive that training, which provides ample resources and education to ensure that they can answer questions. And luckily, because of that integration, if there's ever information that our CHWs feel like they need more training on or more support with, consulting with the providers right here on site and engaging in kind of that teamwork is really helpful as well.
Thank you, Sue. Thank you, Celine. We have two more questions. The first question is, given the rapid changes caused by COVID-19, how do you train or prepare your CHWs for this change?
Here at Shawnee, I think a lot of it has been making sure that our CHWs first feel supported and really have the capacity to manage the increase in need. So as they're out there supporting, as we're out there supporting patients, our supervisors here and the administration is checking in with us and ensuring that, you know, we're okay as well. And I think that's really important because, you know, there's always the question, who takes care of the people who take care of everybody else? And so checking in regularly, I think that our team meetings have increased more during this time because we're constantly having to adapt to changes just so that we're overall in compliance with the guidelines that are being distributed, but also just responding to our patients' needs and thinking outside of the box a little bit. I mean, we weren't doing food deliveries prior to this, and that's something that people stepped up and said, hey, I'm able to do this. But then also really listening to those who say, I think if there's things I can do from home, I feel more comfortable in that way and making sure that they feel supported. So I think that in this time, constant check-ins and conversations and just making sure that people know to speak up when they need additional help and that will be supported.
Yeah, that's about what we're doing as well. One of the things that I find interesting is that, because the teams don't always work together on a common project, there's been quite a bit of opportunity to do things remotely where we can get everybody, where before it was almost impossible. Now that we've had to slow down and do things at a different pace, there's lots more kind of cross discipline training and awareness of programming, where 9 out of 10 times, if there was a family, for example, that had young children in the household, that's what the WIC and family case management and some parts of the community health workers programs would concentrate on, and never talked about the fact that the grandparents also live there. And so now if mom and dad or mom or dad lose their jobs and the grandparents are there are fewer resources to go around. So what can we help the grandparents with that can help the whole family with? It's been an interesting learning curve.
Yeah, here, just basically being open and available for them every time they have a question, every time they need support, and be that support, be that advocate for them when they need something or need help with something, and help them work through the issues that they may be having, whether it's with a client or with technology, trying to help a client virtually, several different things that we do, and reaching out to them. Sometimes, 2 or 3 times a week, just checking on them, making sure they have everything they need, making sure they have, what's crucial during this time is the PPE they need, and make sure they know fully and are aware on how to use it and if they need more. Always keeping that communication line open to them.
Thank you, David. Thank you, Charlene. Thank you, too. And there is one more question, and this is a question that we have received. We've been having conversations with health centers on how you are providing outreach now during the pandemic. One of the strategies, and David was the very first one to mention the strategy to do virtual outreach. And the question is for the 3 panelists. Basically, the question that NCHPA has been receiving is, first, when you do these virtual visits, do you do the telephone visit, or do you have any platform that you get involved with your patients? And second of all, what are you doing to address computer literacy, which is basically another issue that you need to make sure that you are addressing when you are communicating with your patients?
We do have a platform for patients, something called Well app. And I think that what we're finding is that younger people can do it. The older adults have more trouble. And the older they are, the more trouble they have. So for some of our older patients, telemedicine works okay. For some of them, they absolutely insist on coming in, and we accommodate them. We have gone to a scheme where patients are scattered and staggered. And for example, we're doing children visits at one of our school-based health centers, even though the school is closed, so that those patients are not in the same facilities as people who might actually be sick. So it's taken a lot of figuring around, but everybody's being creative.
Thank you, Sue.
Here, sorry.
No, go ahead, David.
Here we use a platform called UpDocs for our patient visits for face-to-face virtual, but we also do telemedicine phone visits as well. And we do have the technology challenges. Luckily, UpDocs is fairly easy to use. They get a text message and they just have to click on the link, but there are some requirements, you know, for the technology to have certain things, and so that's been a challenge. So the telephone visits are definitely a winner with a lot of patients, but you know, for those patients that aren't feeling very comfortable with the face-to-face virtual or even the telephone visit, we are doing also parking lot visits where they actually schedule and come in our parking lot, and we have numbered spaces where they go, and we go out and visit at their car with the nurse and the provider and whoever else needs to be there to help. And so all three of those in conjunction have worked very well, and the parking lot visits have been very well received by patients as well.
And for us, we use a platform called Doxy for the virtual visits, but similar to what everyone else has said, many, especially our older adults, have difficulty navigating the internet if they have the technology on hand. What I've noticed too, I recently had an experience with a grandmother raising her grandchild, and of course with schools, our Jefferson County Public Schools has been mailing, or making sure families have laptops in the home to finish up the school year, and her grandchild spilled something on the laptop that they provided, and she didn't know what to do, and there were so many different steps involved. So making sure to support patients in that way, but on the virtual visit end of it, what we're finding too is that patients who may not even have a phone, many of our community have difficulty with just phone access too. So getting connected with the mayor's office's digital inclusion program was a big game changer for us. So looking for resources like that, but also the what is it called? There's the Lifeline program that's nationwide, where people can get one free cell phone a year with a certain amount of minutes, and at least that can get them access to just the telehealth resource. So we've been helping patients sign up for that and getting them phones as well to increase their options for visits. So it is a lot of thinking outside of the box and reaching out and building relationships with different agencies so that we can maximize our resources and inform our patients about what's available out there.
Excellent. Thank you, David. Thank you, Sue, and thank you, Celine, for your responses. We are almost close to the end of this webinar. So one more time, I would like to thank Dr. Abdin Novoa Rios, Sue Vega, David Preston, and Celine Mutoya Maria for the presentations and for this excellent live activity. All attendees, you are going to receive the recording, the slides, and if you still have any questions, please feel free to send out your questions, and we will make sure that our panelists for today's webinar receive the questions, and then you get your responses. One more time, we are the National Center for Health and Public Housing. Please contact us if you have any questions, and thank you so much for attending this activity. Have a great afternoon.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.